Hello, everybody, and welcome to the Bad EM podcast. My name is Daniel Still, and I'm your host. Bad EM stands for Brave African Discussions in Emergency Medicine, and this is a platform we use to try and find African solutions for African problems. In this episode, I'm delighted to have Professor Kathryn Chu, who is the head of the Division of Global Surgery at Stellenbosch University. She is a surgeon with an extensive career both in clinical medicine and academia. And today we're chatting about global surgery and what it means, what we can do to improve access to surgical care. We touch on shared ownership of patients between treating departments and treating hospitals, based on location, level of hospital, and training capacity. We dive into how specialist departments need to start taking a more regional approach to the service they provide, instead of focusing entirely on their own hospital and the patients when they arrive there. We then go on to chat about Western and traditional medicine and how we can help each other in order to facilitate better outcomes. Without any further ado, welcome to the show, Kathryn. Would you start by introducing yourself and giving us a brief background of your professional career so far?
Yeah, well, thank you very much for having me on your podcast. So my name is Kathryn Chu, and my background is I'm a general and colorectal surgeon. As you maybe can hear from my accent, I was born in the U.S. and I did all my medical and surgical training there. And I moved to South Africa 20 years ago now. I initially came here to work with Doctors Without Borders, or Médecins Sans Frontières. They opened a medical unit here in South Africa, initially in Khayelitsha, and it's now an observatory. But I was their surgical advisor and their operational research person, epidemiologist for surgery, and then did surgical missions with them. And then I have since worked for the Western Cape government as a surgeon in our regional and district level hospitals. I've also worked in KZN and Mpumalanga, and I've spent some time in Rwanda, 2 years specifically, also helping start up their general surgery residency program at the University of Rwanda. And currently, I am the director for the Center for Global Surgery at Stellenbosch University, and I've been here now for 5 years.
Awesome. Thank you. And for people who don't know or who are less aware of what global surgery is, would you mind giving us a brief definition, for lack of a better word, of what global surgery is and what your department does?
Sure. So global surgery simply is improving access to surgical care for all people who need it. So probably a third of the health conditions in the world can be treated or cured with surgery, but not everybody, especially in this part of the world, knows that or thinks of it. We usually focus in on more of the infectious diseases, for example, HIV, TB, malaria, but actually surgical conditions kill more people worldwide than all those conditions combined. So surgery is important, but as we'll get into more, hopefully in this interview, is access to surgical care is difficult for many of our patients, particularly those that don't have insurance or live in rural areas. So global surgery is the study and then implementation of finding solutions to get improved access to surgical care. The term global, especially for those of us in South Africa, is really confusing because for most of us working, especially in the public health sector, we see that there are a lot of challenges to getting patients access to surgical care, whether it's just long waiting lists in the hospital, not enough theater time, or even just simply how to get to the right hospital that can provide the care. But that is just in our own backyard. So we don't have to look outside South Africa or our own hospital. The term, I do have to say, is a bit colonialistic. It came from this term global health, which was essentially started that term by North Americans and people from academics from Europe, basically saying that they wanted to go to poor countries and help improve healthcare or health systems there. And then the term global health, then global surgery was sort of adapted from that term.
Global as in everybody else. So not including us, but we are going elsewhere to practice or to help other people, essentially.
Yeah, and exactly. And even in that term, it's a bit sort of paternalistic or colonialistic in that, like, we have all the solutions and we will go and help.
Yeah, very much so, yeah. So you mentioned one of your big aims is to create easier access to surgical care for people without physical proximity to big surgical services or the correct hospital, or doctors trying to access surgical care on behalf of their patients, etc. When it comes to specialist disciplines in general, so not only surgery, but with your expertise regarding surgery, you can focus on that. Do you think there should be a more bottom-heavy distribution of specialist services and specialist advice, even if it's not physical presence, with a more equal spread to more remote facilities or cover, etc., instead of a doctor in a regional or district or primary care facility always having to refer upwards to a more central facility, who then gets feedback from their consultant, who then feeds back to their junior, who then feeds back to their senior, as opposed to something like outreach clinics where specialists can run a weekly clinic or even give direct advice for a whole region as opposed to just one facility.
Yeah, so maybe just to reiterate, I think the biggest problem in terms of access to surgical care is what you alluded to, is that most of the appropriate care is given at tertiary hospitals which are usually located in urban centers. And that is simply because most of the surgeons and all the surgical subspecialists, neurosurgeons, orthopedic surgeons, ENT surgeons, only work at those hospitals. So I think the first thing that you sort of alluded to is that at least in district hospitals, none of those surgical specialists work, even general surgeons. So I think the first issue is the manpower. And so if a patient who lives in a rural area can only be referred from the clinic to their district hospital, then the general doctors and sometimes their community service doctors who have very little experience with identifying surgical conditions, let alone what to do about it once they do, which often is operative, like how can they handle that better? So I think there's two approaches to this. The first is that we have a shortage of surgeons, I'll just call them, in this country, and they're inequitably distributed. Most of them want to live in big urban centers where they have peers and where there's hospitals with lots of operating theaters. And so one is to train more specialists and try to...
And not to mention their own personal reasons, like families and schools and general personal reasons, yeah.
And I think those are really important because most of those are really the rate-limiting step. Because you can train more surgeons, then try to get them to work at district hospitals. But even if you throw more money at the situation and give them the rural allowance, for those reasons, Dan, you just mentioned, like no good schools for their children and for their spouse or partner, if there's other like employment opportunities. And oftentimes for the subspecialties, at least, if someone's trained to be a hepatobiliary surgeon, then they really want to be focused on those cases, and recruitment for those patients in district hospital would be difficult. So that is probably not the solution. The move internationally and the recommendation by the World Health Organization is now to have essential and emergency surgical services offered at the district hospitals. What we call the district hospitals, it's also called first level hospital. In this country and in many, the government doesn't recognize to hire specialists, including surgeons, at those hospitals. So by definition, the only specialist that can be at a district hospital will be the family physician plus the general doctors that are working there. So I think the first thing is to try to find a training scheme or way of working where the family physicians can diagnose and treat some of the essential and emergency surgical procedures. So let me just clarify what would be an emergency or essential surgical condition. Would be something like an incarcerated hernia or a gangrenous leg that needs an amputation. It wouldn't be trying to teach non-surgeons how to do a liver transplant, for example, at a district hospital, because that also requires a health system to have ICU beds, specific medications available, colleagues that work in nephrology if it were kidney transplant, and access to drugs and dialysis that we just wouldn't have at a district hospital. This would be sort of the bread and butter emergency operations, fractures, for example, for orthopedic surgeons. So the first thing is, could that training happen? And that can only happen with the cooperation of the surgeons and the surgical societies. So at the moment, there has been resistance from surgeons and particular surgical societies speaking out to say nobody can do these operations or care for these patients except for us. And if surgeons stand in the way, then family physicians and general doctors are not going to venture into that territory, right? They're afraid because then if something happens, and there are always complications, then they don't want to be criticized for that. The important thing then is to feel that all patients that drain to a specific regional hospital where there are general surgeons, orthopedic surgeons at least, or to a tertiary hospital, all belong to that group of providers. So those district hospitals, those clinics, they all are part of an ecosystem or a health system that specialist is in charge of. So if a patient is at the district hospital, but that district hospital wants advice about a surgical patient, that is also the responsibility of those surgeons working at that hospital. I think you've probably discussed Vula, and I saw that you had interviewed the founder, Will Latham of Vula. So for those of you that don't know, Vula is a referral app that was initially started exactly for rural doctors to be able to refer their patients to specialists without having to pick up the phone, try to find the operator, try to find the resident on call, which, oftentimes didn't work, especially with surgical disciplines where the person that get called was in the operating theater. And then the rural patient in a clinic never got an appointment, would have to come back a month later to get that appointment, causing more delays to care. So Vula has been a fantastic referral app, and we have already looked at how it's also being used to give advice. So instead of, no, we don't want your patient or send your patient tomorrow, it's, why don't you try this, this, and this? What's also worked really well are WhatsApp groups. So at Mitchell's Plain, which is a district hospital here in Cape Town, have been working with their referral clinics, and about 150 providers are all in this group, so that fracture cases, usually traumatic fractures, are discussed, or the cases presented on the group, and at least 1/3 of them were managed with advice only. So this wasn't just, no, we don't want your patient, but it was, here's what you should do. Now, orthopedics is a specific case because there's pre and post x-rays, reduction x-rays. And so that's quite an objective way of seeing, is this good enough, or does the patient still need to be sent across? But
has the patient improved or not? It's more difficult when it comes to abdominal pain, and is the patient peritonitic?
Exactly. But I think those are both examples of ways that specialists and non-specialists or people of different disciplines can communicate. So at a district hospital, back to your original question, I don't think that making it bottom heavy in terms of more consultants, but certainly more training and more working together. So specialists need to be in discussion groups, consultation groups with those working at district hospitals in order to discuss cases, because that could already eliminate a lot of this need for a patient to wait and then travel quite long distances in some parts of our country to find out that, oh, actually, we weren't going to do anything about your keloid, we just don't have time to treat that, or some advice about how to do the actual operation. And then you also mentioned outreach. So for sure, a lot of this advice and communication and assistance can only work if each group knows one another, right? So if I'm the surgeon at the regional hospital, I would like to know what are the surgical skills of the person working in the district hospital. And that can really only work if I also set up some rapport, do some teaching rounds and operate with them at that hospital. Ideally, also some in-reach could happen as well. So I think those would be the ideal setup for this country.
And with regards to the remote advice platforms like Vula and WhatsApp groups, as you alluded to, it empowers the doctors working in the referring facilities to upskill themselves if it's an advice-giving thing, or if it is something that they wouldn't have otherwise necessarily felt comfortable doing. But now, as the specialist surgeon, you have given advice on what to do, which then empowers them to then do that, which they might have felt skilled enough to do, but not comfortable enough to do because of what you said earlier, like this is not within our skill set. And there's been pushback from specialists before about us doing it here, etc.
Yeah, and also the advantage of these sort of electronic platforms is that one can capture what type of conditions are being referred, right? So if you find out that there's many Colles fractures being referred, then the specialists can target their trainings for those clinics or district hospitals to that specific condition if they feel like that's something that can be done at the district hospital. So, I mean, that kind of brings up, because often people talk about what is the scope of practice. And so what is the basket of conditions that we're going to allow this district hospital to do? And I think that is hard to define nationally or even provincially, because it depends on who's working at the district hospital, what the regional surgeons are comfortable sort of giving advice. Depends on the distance. If the distance is pretty close and the regional hospital has capacity, they may say, well, send us all your amputations, because the anesthesia for those patients might be quite tricky. Not so much the operation, but the anesthesia. And so it's best not to do it at your own facility. Or they might find out, oh, there's a lot of burns coming in, so we'd like to teach you how to do the skin graft and help set up the dermatome and all that stuff. And so that could be a win-win.
So we've touched on it already, but with regards to a sense of responsibility with a department, so this is basically the essence of global surgery, but I feel that in South Africa, a lot of specialist departments, including emergency medicine, has a very limited sense of responsibility. So we will deal with the patient when they arrive at our doorstep, and whatever happens before or after that is not necessarily our problem. We just have to keep our ship afloat and deal with whatever comes to us, which is not necessarily the right way to look at it, as you've alluded to. We need to have more of this is our service for our region approach, where we are responsible for the surgical burden of our area, for example. How do we move the thinking toward that? So, for example, I don't want to pick on anyone in specifically, but let's say let's say dermatology, for example. They have a clinic at the tertiary hospitals, and they take referrals from everywhere, and they basically see the patients when they arrive, and if they're long waiting list, they are long waiting list, and that's just the reality of the situation. But what we might need is for them to expand their own services by taking more of a regional approach and saying, how do we capture this early? How do we use WhatsApp groups and Vula and outreach and inreach to do that, as opposed to the public health doctors and the people like doing global surgery like yourself and the family physicians and et cetera, doing that for them? How do we make it a more responsible, I don't know what a better word is, but more of a shared responsibility?
Yeah, I mean, I think the shared ownership of persons with the conditions that you're kind of managing is an important paradigm shift or change in the way of thinking. And it probably needs to happen from the medical school level, because it's pretty, I want to say, normal for surgeons and doctors that work at a hospital to say, I'm not going to worry about it until it hits my front door. And I think in some way that is because we have such a high burden of disease anyway, that otherwise some specialists or some doctors feel like they're drowning in the amount of patients that they need to take care of. And I think historically, we haven't looked outside our own four walls of our own hospital because we didn't think we could do much about what happened up until that point. So it could be for multiple reasons. One, I just need to put blinders on because it's enough for me just to do my 80 patients in my outpatient, let alone open my doors or my email to all other people and help them with all their patients. But also perhaps they felt that they couldn't do anything with it. I think that is changing. There are a lot of doctors working in the public sector now that are thinking outside of just who comes to their front doorstep, often because the more the work they can do upstream or downstream, whichever way you want to call it, puts patients in a better condition to be operated on. So if you can catch those colon cancers earlier, then you will do more operations for cure than you were for palliation. And I think we're all here because we want to improve health and well-being, not just tick the boxes of the number of patients that we see. So I think that already helps. Also, a lot of services, for example, are using Vula to take appointments for gastroscopy or pre-screen patients for colonoscopy colonoscopy and gastroscopy, just so that there has been some workup that was appropriate to get the patient to them. But I also think that the reality is we're limited by the number of staff we have. So most public hospitals have their specialists or consultants numbers cut. And so the ability to also do outreach and to be able to spend time on VULA and is a little bit less than we'd like. Some areas have more and some have figured out creative ways to take, one post from the district and sort of make it at the regional hospital, but then that person is sent out as full-time, a roving outreach person. But I guess it has to come from early teaching to believe that your responsibility is outside your own hospital, especially for surgeons who think that their territory is inside the theater, right? So there's also that belief that you don't even come to theater until the patient and everyone else is already ready, and then you just show up.
Yeah, even within your own hospital, there's like a mini version of that whole macro systemic issue. Yeah, you would say even an emergency unit can be thought of as like the district hospital of the hospital, and getting people out of the emergency unit and some other disciplines have that they will arrive when they arrive attitude towards their ward or towards theatre, like you said. But also, like you said, the more work you want to do upstream, you might have you might not have 80 patients in your OPD anymore because you've given people remote and better advice, and now you have 60 or 50 appropriately sent patients in your OPD that are more suitable for your specialist services.
Oh, absolutely. And I think that surgeons or specialists that have figured that part out are then more interested in kind of this health system approach.
You also touched on my next question, which was preventative or screening investigations and how difficult those can be to facilitate, especially the further you are away from places that can do investigations. So specifically for malignancies, there's often a sense that people have to have quite clear and definitive symptoms before a receiving doctor will take them seriously enough to do a more urgent workup for them. And as we know, symptoms of a lot of malignancies are very vague and non-specific. For example, a colon CA can have 1,000 different symptoms before you get a palpable mass with change in bowel habits and iron deficiency anemia or something like that. So do you think there also needs to be a move toward more and early investigations as opposed to a longer waiting time for someone that you're not completely convinced about, who might need a scope, who might not, but with more access and resources would probably get a scope much sooner to avoid more invasive, more costly, more time-consuming procedures or palliative procedures down the line?
Yeah, so I think if we're talking about our public health sector, screening for abdominal malignancies specifically just doesn't happen, because screening means they have had no symptoms and it's just the average risk person. So that already is tough, a difficult pill to swallow, because the private sector will screen for breast cancer, they'll screen for colon cancer, colonoscopy. And so those are, unfortunately, the luxuries that our public health service doesn't have. And then once patients have some symptoms, it becomes the diagnostic investigations, right? So constipation or a little change in bowel habits, very, very vague. And so I think your question is, if the best test to investigate that is a colonoscopy, how do we or should we get patients who haven't presented half dead or the bowel obstruction some of those tests? I think that is the difficult part now, balancing the resources, because most of the endoscopy services, are run by surgeons. We don't really have gastroenterologists, at least so many of them in the public sector. And so there are very few lists for that. For gastroscopy, there is some pretty good screening or pretty good criteria to ask. There's some, weight loss, hematemesis, I think is a quite important one, in order to sort of push them up the list, if you will.
The prioritization list.
Yes, but it is difficult because colon cancer, which is more near and dear to my heart. We're doing a national sort of audit now, and I think that more than half present as obstruction or perforation, which is way too late. And if you've had one of those two things, you're probably not going to be cured. I think the flip side, though, is that if every one of them did get access to the screening or the diagnostic colonoscopy, then there would be so many patients who would qualify for that. How do we then rank those? So I guess it has to be something in between. Again, the use of VULA to be able to really drill down, like you're really worried about your patient, can we, discuss, because it's a 4-month waiting list. Can I bump them up the list somehow? But again, that doesn't help everyone, because it's just, if you bump your patient up, somebody else has just dropped back, and then they're going to start phoning. It's like surgeons battling it out with the head anesthetist on like whose patient should go first, because they all need to be operated on, but they can only do 5 a day. I do think, though, there is still room for example, family physicians being able to do sigmoidoscopy at the district hospitals. Gastroscopy is a real need, and that we've discussed with several of the regional surgeons that they'd be happy to train and allow non-specialists to do that procedure. We've tried different things where you can sort of be available remotely. So there's something called the HoloLens. It's just one kind of virtual reality glasses that the operator can be using and somebody else can be watching what they see, or you can just feed the endoscopy live stream to another computer. Also, diagnostic endoscopy is pretty straightforward to do, but then if you see a malignancy, they might not be able to biopsy or treat it. They might have to send the patient then, but that already eliminates
the other 9
exactly
endoscopies that they did before that didn't have to come. Yeah.
Exactly. But I know that there is at least one hospital, Worcester, in the Western Cape, that looked at their endoscopy malignancy pickup rate, and it was like 30%. And so that's too high, which means that they need to see more patients.
That means they're not seeing enough people.
Exactly.
Yeah.
So they were ones that were hoping and thinking about how to get district hospitals to do their own screening or diagnostics on less acute patients as a potential solution. So,
yeah. I think the question comes from a place of referring highly suspicious patients for non-benign lesions to surgical services, and the less specific your symptoms are and the less sure you are, the longer your appointment time is going to be. And that, I feel, needs to do a reversal, because if you have a patient with 10 out of 10 symptoms, they are likely going to be for palliation, and then they don't necessarily need that investigation
anyway.
at all. You know what I mean? So it's difficult to, and I've done a separate podcast about palliative care in general. And if an investigation is not going to change your management, you shouldn't really do it. But you still have to have a certain level of surety about your diagnosis to say that somebody is for palliative care.
Yeah.
But I feel a lot of the time that if you have a vague symptom, you've got almost zero chance of getting the surgical registrar on call to take you seriously. Or on VULA even, they'll say, okay, G-scope in 6 months. But if you have everything slam dunk, they'll be like, okay, cool, let's do a G-scope next week. But then the patient's not going to benefit from that because it's an advanced non-benign lesion already.
Oh, yeah. I mean, if you say your patient can't swallow even water for the last 10 days, you'll get that patient across as an inpatient, but they'll have inoperable esophageal cancer that can only be stented. But, let me just give you an example of low back pain, right? Mm. So that's the dreaded referral for neurosurgery and orthopedic residents. But, you might feel that your patient needs an MRI. But how many people would we MRI for low back pain to pick up one spinal tumor or one, nerve impingement that actually will require some operative? It's probably 1 in 1,000, 1 in 10,000. So, that's an extreme example. Mm. But I guess in the public sector, it's difficult to get into these clinics, and that's probably what they're thinking. They're not looking at the person in front of you that you're looking at in your clinic, feeling like this person's really got something wrong. This isn't just low back pain. It's
they're just getting their 15th referral of the day with the same problem.
Right. But if you are in private, the chances of you getting that MRI is probably pretty high because somebody's going to be reimbursed and it's all fee for service. And so someone's going to make some extra money by seeing your referral, even if they didn't feel that, at least by hearing about it. So I agree. I mean, I think that this ability to communicate on Vula or WhatsApp group has helped, but it's not perfect, right? It's still going to be difficult because in general, residents are tired and overworked and they don't want more patients. So you're also fighting that as well.
I think that's a general feeling with everybody in the healthcare system, especially in the overworked and overburdened government healthcare system in South Africa. Everybody is sort of has their guard up about we are already full and at capacity, therefore we can't take your patient. And everyone on the other side is like, well, we need to move this patient along because we're also full and at capacity. And that, from a start off point, that's not a good place to start when everyone's got their hackles up like from the get-go.
Yeah, although I do have to say that behavior is modeled. So I have seen services where the consultant really has an open door policy. Like we'll take everyone, and as soon as like we have a patient going back to X hospital, so we'll take another one of theirs. And like consultants that go that extra distance, their juniors will model that behavior. Because if the consultant is bad mouthing the other hospitals and saying, what a jerk, and like, why are they referring us inappropriate patients? I mean, that term really gets me because what person is inappropriate? I mean, that person has their symptoms. Maybe it's not an operable patient, so it's not interesting for the surgeons who are learning, but the person isn't inappropriate. So this is inappropriate patient. But I think that kind of behavior is modeled. So yes, of course, the residents are tired and overworked and they sort of cringe if they've got in a consultant that's like admitting everyone. But I do think consultants that show that they care about patients and are trying to make a way for them to have more come to their hospital, I think then the juniors just also pick that up and will do it as well. So that's quite important.
Or not necessarily accepting everybody, but if there is a patient who they feel strongly about, who is for lack of a better word, an appropriate patient, some consultants will go the extra mile and make a plan, like you said, maybe send a patient back who doesn't need tertiary level inpatient care anymore, and we can take one if they give us one, etc. And that, like you said, goes a long way. And also, you touched on a sense of blame of the other hospitals for sending inappropriate patients. And that goes back to what we were discussing earlier about having a shared ownership and shared responsibility for a service for your region as opposed to your hospital.
Well, it's like, if you say your children are badly behaved, or if you say someone else's, it's usually the fault of the parents. So I'd like to say the same thing. If these referrals are coming in that you think aren't worked up, then it's your responsibility as the person at the highest level hospital to then either provide a mechanism for educating those doctors or providing a way for that person to have the appropriate workup. And frankly, a lot of the workup that's requested on Vula is useless because the person needs to come across whether you order those last CRP plus the white count or not. But I mean, it doesn't matter, but they're just sort of trying to think of anything they can to stave off the referral till after 8 a.m. when they go off call.
Trying to delay the process.
Yes, we've seen all that too.
And with regard to inpatient versus outpatient care, for a lot of, even at district and primary care level, or not primary, but district level, there's this huge gap in access time between inpatient and outpatient care. So a patient will come along and either it's a non-urgent or semi-urgent thing, and then the waiting times are, say, 6 weeks to 6 months to 2 years for some surgical services, like a cataract removal, for example, or a semi-urgent to urgent thing where the patient is either unstable, and that's a no-brainer. Everybody, you must come across as an inpatient if you need any form of supportive care or if your risk of deterioration is high, etc. But then you've got your patient who is not unstable in any way, but is deemed to need a more urgent service. And the patient comes via the stream of patients. They come to the emergency unit, then they sit on a chair there for a bit, and then they wait for a bed in the ward, and then they go to the ward a day and a half later, and then they have some sort of operation or procedure done, investigation perhaps, maybe 3 or 4 days later when there's a spot for them. So their need was met 4 days after the referral. And their resource utilization has been quite high for that 4 days because they've needed a transfer, they've needed a spot, a chair, and then a stretcher, and then a bed in the hospital, nursing care, etc. So the question basically is there more of a capacity for a rapid access service or a separate entrance? And I know a lot of hospitals do have this already, like a surgical admissions, but most places don't. And yeah, how do we circumnavigate that?
Yeah, I mean, I think this is again back to the problem that we don't have enough services in the public sector except to address the most dire things. And, clearly a well-functioning healthcare system treats conditions, let's say like an inguinal hernia, before it incarcerates and the person is in extremis. In order to be bumped up all the way to the top of the list, they have to have like life-threatening issue. And so sort of preventative or, catching malignancies early, but then they're not sick enough to sort of meet that life or limb criteria right off the bat. So then you're having a lot of people stuck in the middle. And so, I mean, even the person that's waiting 2 years for their hip replacement or their cataracts, I mean, for that person, if they knew that there was another way to get the service, they would all use it. So I think that, already a lot of patients know that if they really want something done, they just go sit in the emergency department and yeah, you have to sit on a chair for 36 hours, but you will, as you said, get your service in 4 days instead of 4 years. But I guess it's difficult because who qualifies for that? Because I would argue every outpatient qualifies for that. Nobody wants to wait 2 years because something will likely get worse in those 2 years and maybe, even be life-threatening.
Even just morbidity.
Yeah, you're not just trying to save lives, but you're trying to allow people to get back to work. Even somebody with low back pain that might have just sciatica, but they need to have some appropriate, physio or something in order to, or dietitian or whatever could at least ameliorate their problem, and they just aren't getting those services. I mean, if you just look at the operating theater as a small example of the systemic problem, is that cases that are not life-threatening often get bumped for that gunshot wound to the chest that comes in, and all the cancer cases fall off the list for that day. And definitely the biliary colics and the hernias and fall off the list. And rescheduling them is difficult because they come from far away, and so you don't want to discharge them, but then they need the bed. And so sometimes they're just discharged with no follow-up date. Because a tertiary hospital should be doing like 80 to 90% elective cases, and only 10% of these emergencies. And the districts and the regionals should be doing more of the emergencies. But because the districts don't have capacity to operate on all these emergency cases, at least the straightforward ones, then these complex vascular, colorectal, neurosurgery, tumors, cases that are supposed to be done at the tertiary hospital fall off the list because then somebody who needs craniotomy for a subdural hemorrhage then bumps that person who needed, their glial tumor removed. That is a bit of the sad reality of this country.
Yeah, well, I know I stand to be corrected, but I think Albert Lutuli in Durban is a quaternary hospital that is completely closed doors. They don't have any walk-in service. You have to be referred. Obviously, that would be a nice thing to have for elective surgeries or referral-only surgeries, but that's a different conversation for a different day.
Yes, agreed. Won't comment on that one.
I've got 2 more questions, but the last written question. If you had a magic wand that you could wave and manifest one tangible thing that would manifest tomorrow, what would that be?
Well, I think the low-lying fruit or the easy win is to get better radiology services at the districts and the regionals. So for sure, in surgery, head injuries, we would like to have better CT scan hours. A lot of our hospitals have CT scanners, but they either don't work or they only function for like 2 hours a day or not after hours. And so being able to actually get those services running 24 hours a day, I think would be really helpful, even just the x-ray. So that's the other thing would be ultrasound capacity. So if all medical students and interns were taught how to use ultrasound, not just for the FAST exam, but for quite a few other diagnoses, I think that would really help sort of investigations at lower level hospitals. And so patients could be triaged a bit better and diagnosed earlier.
And is that happening? Are we teaching undergrads? I don't know if you would have any input into that, but are we teaching undergrads ultrasound at the moment?
No, I don't think so.
And then going back to the term global surgery and a colonial mindset, something I found very interesting when we were chatting at AFChem, you mentioned some of the data gathering work you were doing around the Eastern Cape with the traditional healers and how people have people need to mentally buy in to surgery and operable treatments as a possible treatment option from the start in order for them to access our services. Could you tell us a bit about that?
Well, so I think that a lot of what we've discussed here has been like delays to either reaching the right service, or then once you get to the heart hospital, like delays or limitations in like how to treat the people. But one of the major issues that's happening in this country, but many parts of the world, is the decision for the patient to even seek care. So they might have symptoms. I'll just say, for example, the patient has breast cancer. They just know they have a breast lump. May or may not be painful, but there's a lump there. So in South Africa, 80% of the population uses traditional healers, mostly in the rural areas, but even people in townships, for example, use traditional healers. And some of that depends on what they believe that the origin of the disease came from. So we might say breast cancer, mutation in cells, that are overgrowing, and they might think curse from my ancestors, or somebody's angry with me. And so there's some imbalance going on. And so that drives the decision, for example, to seek a traditional healer sometimes, because they also treat those aspects of the disease. But now there's been more belief that, and it seems pretty exciting data, that traditional healers are not a completely separate and different system than, I guess, HPCSA certified practitioners, although HPCSA also recognizes traditional healers, so that's something else.
Western medicine.
Yeah, okay. So we said the formal health sector and then traditional medicine or indigenous medicine. But there is a willingness to work together, both from the formal medical side, so nurses and doctors, with indigenous healers. So how they would work together, I think, still remains to be seen. At the very least, the indigenous healers could be an extension of the formal medical sector in the sense that they might be able to help identify, or maybe not diagnose, but see that there is a breast mass or there is a burn that's infected wounds, and be able to say to that person or patient, I think you need to go in to see the formal health sector for this one. That is, of course, a very unilateral way of working. It's basically the indigenous healers are doing work for the formal medical sector. So we do need to think, how can then we do something for them? Just like we were talking about global health, it's not just people from America sending their medical students over here to practice on our patients, but then how can our students also benefit by going across? So we haven't quite worked out how that would look, but at the very least, being health promoters, or we're doing one study on screening, seeing if indigenous healers can screen for diabetes. About half the cases of diabetes are undiagnosed. And so if the person came in for low back pain to see the indigenous healer, they could also just do the simple screening tool to see if the person was at risk for diabetes and then go into the formal sector. So I think there is promise in working together. The other thing, this is my own personal opinion, I wouldn't say for all doctors, but seeking care with indigenous healers is part of the culture for a lot of people here. We're not going to be able to change that. So it's hard to say, well, what they're doing is totally wrong and what we're doing is right. Your job is just to get the patients across as fast as possible. I think we have to acknowledge these people live in the communities. They have access to patients quickly. They speak their language. And so, working together could be really beneficial for our patients.
And also, I think a lot of, in our formal medicine training and setting, or at least in how we practice, time is often very limited. And for a lot of self-limiting disease processes that aren't going to manifest into something that needs surgery or antibiotics or oxygen or anything like that, the patients are getting a much better service out of their traditional healers and or any form of non-Western medicine, because the people have time to listen to them, and it could be a problem that is self-limiting to start with from a physical perspective, but from a mental perspective, they are getting a far better, more comprehensive service from from non-Western healers.
Agreed.
Is there any other exciting research that your department is working on that you want to share with us?
I think we are now more and more trying to do what is called implementation science, but it would be essentially, trying out a new mHealth app, for example, or doing some more training. For example, working with groups we haven't worked with before, community healthcare workers on, preventing amputation from diabetes or peripheral vascular disease, and then trying to see how acceptable it is, as well as how effective that screening tool is. And so I think before we would just come up with something and do it, but we never actually knew, from the point of view of both the patients and the practitioners, so healthcare workers or the traditional healers, is this something that they can use? Do they think you can work it into their everyday practice? We're trying to do more of that.
And do they like using it, and do they think it's useful?
Exactly.
Well, I think that's all for now. Yeah, thank you very much. And I'm sure our listeners will find that very interesting and engaging. Yeah, thanks for your time.
Thanks a lot for the opportunity today.
So to summarize our conversation, we chatted about the meaning and origin of global surgery. We spoke a lot about access to care and specialist advice, with a move toward upskilling regional healthcare providers, use of apps and different referral pathways to access quality advice and service, and the inequities of public and private hospitals when it comes to capacity for screening and early diagnostic investigations. We then spoke about interesting work being done with regard to Western and traditional medicine to help each other in a more progressive way. And that's all for this month. Be sure to review and subscribe on any of your main platforms, and to send to a friend or colleague who might be interested. If you want to get in touch, find me on LinkedIn or email me at dan@badem.co.za. Please also follow us on Instagram and Facebook, which is @BraveAfricanDiscussions, and X or Blue Sky as BadEM. Thanks all for listening. See you next month. Bye bye.